Hey, good evening, everybody. This is Dr. David Alpan. I'm excited to present to you about using accelerated orthodontics to grow your practice, or to make your treatment more reliable, or to make your treatment more predictable, or to either get what it is that your patients want in a shorter period of time. I think all those things apply here. How do we do that? How do we incorporate technology to make our life easy? And I think that we all are so familiar with our iPhones and our various gadgets. We're all really good at those things. And so this is just another gadget, some tricks in the toolbox to add to your armamentarium. And just a little bit about myself. I'm not employed by any dental company. I own no stock in any of the acceleration companies, no securities. No family member is employed by one of these companies or owns stock, and I've consulted and evaluated products for various different companies over many years. And this is a little bit about myself. I put these couple pictures in here because people always tell me I don't throw any pictures in there, so I thought I'd talk a little bit about myself too. I like to hunt and I like to race cars, and funny enough, I grew up in LA, and kind of feel like maybe I should have grown up in the South or something like that. But there's when I went to school, graduated in '96 and from dental school, and graduated from ortho in '98. I was 22 years old as a dentist and 24 as an orthodontist. I started really young. 2 private practices, LA and Beverly Hills. Started in 1999, and I just added Century City in 2016. I had a practice in Las Vegas that I just sold last year in 2015. I started that in '99. I've been a part of the Ormco Insiders Group, 3M Research Panel, started using accelerated orthodontics in 2012. I've been a speaker and consultant for Invisalign for several years, kind of fell off around 2008. A lead provider for Invisalign for a long time, and Center of Excellence Incognito provider, key opinion leader for Propel, and also a speaker for Acceladent. So I hope to incorporate all kinds of cool things. So these are some pictures of my family. There's my wife, Mary, and my 2 kids. My son is 4.5, my daughter's 2. Everything that I do is nowadays for them. I guess I started as number 1, and now I'm number 4. But that's okay. My wife says she's got 3 kids at home. I guess I'm one of them. And then there's my son in his little race car. And there's him when he was really young, learning how to race. So I'm definitely into racing, and so is my son. And the upper right-hand corner, we were just in Hawaii for the Ormco Insiders meeting. It was a lot of fun. So my overview for today, the history of accelerated orthodontics. Where did it start? How successful is it? What's the science behind it? Or do we have research? I'm going to get into some of the animal studies and some of the human studies before and after cases. I have some of my own to share, and then some other practitioners that have done some incredible work. And then we'll talk about advantages and fees, and then how to market micro osteo-perforation. And funny joke, just to go back to my family, my wife is Filipino and I'm Jewish, and so our kids are a combination of both, so we call them Jewpinos. So that was just a kind of funny aside. History of Propel devices started in 2011, was manufactured and registered with the FDA, and clinical trials began. In 2012, the NYU studies came out, and almost 300 treatments were performed by then. I put some samples on the screen there of what the different Propel manual perforation devices look like. And there's, in 2013, there was over 6,000 devices in private practice, integrated in over 25 universities. By 2014, over 200,000 treatments have been performed, and also was awarded the Pride Institute Best of Class winner for a new device. And then in 2015, over 350,000 treatments and 18 different industry journals that it was published or came out in, so it's been very popular and very well received. Perforation, or micro osteo-perforation, or manual perforation, which is now what we're referring to it as, is pretty much, in my opinion, the leader in science for acceleration orthodontics. And they recently just launched vPro 5 to help seed aligners. So we're going to talk a little bit about that too. And there's a picture of the vPro 5 unit there. So what are manual osteo-perforations? So we also like to call them dimples or mops. Basically what we're trying to do is stimulate a cytokine release, stimulate inflammation in a local area to cause the body to respond faster. So triggering the body's biology, or the process of orthodontic tooth movement, which is a combination of resorption and apposition, and that process that happens requires inflammation. And so if we apply something that's going to create more inflammation, we're going to see the body kind of speed up, or what we call a RAP effect, or regional accelerated phenomena, where the bone changes over faster and is stimulated faster. So the osteoclasts work better and faster, and then the osteoblasts also work better and faster because of the increased cytokine levels, or the inflammation, if you will, around that area. Accelerate overall orthodontic tooth movement and treatment, and you can use it with almost any type of orthodontic tooth movement as long as you're moving teeth, and you can apply it to any of those various modalities. I tried to pick as many as I could. I'm sure there's probably a lot more. These are the questions I ask myself. If I'm starting a new technology, should I be the first one to try it? You know, I look at that picture down there at the bottom. It is a beautiful picture. It feels kind of like somewhere in Scotland or someplace like that, or Ireland, and there's those sheep following up the hill, and you know, there's always that one sheep all the way at the top, and you know, so should I be the first one, or should I be somewhere in that group? Do I want to be the last one? In school, they always said, don't be the first and don't be the last, so I guess you should be kind of somewhere in the middle. I tend to be like right behind that first guy in that first little group right there, and so I tend to be a little bit of an early adopter of technology, especially if there's science behind it. So I threw in a picture of science, but then I also threw in a guy that looks a little bit confused. You know, should I wait? Should I start? You know, maybe this is so new. I don't know if I should be the first one to put myself out there. And so I happen to be one of those people, and been putting myself out there now for the last 4 years, and I really like it, and I'm getting great results, and I think it's something that I should share with everyone, and everyone should consider it as part of their armamentarium. So if we know that inflammation is tied into the cytokine response, which is what we're measuring, in the studies they're actually measuring the intraclavicular fluid and noticing that the cytokine levels are greater when we have tooth movement, so there's inflammation, and then we're noticing that cytokine levels are reduced when we use drugs like anti-inflammatory drugs. So many studies have been done as far back as 1988. So it's well over 15 years of studies that's showing that if we use non-steroidal anti-inflammatory drugs, we will decrease tooth movement, or the rate of tooth movement. And so that rate of tooth movement is the turnover, the biologic turnover of the apposition and resorption of the bone. And so we're telling all patients now that are undergoing orthodontic treatment, whether they're getting acceleration or not, that they should only take Tylenol so that they don't slow down the way the teeth move. One of my friends, he charges extra if the treatment goes longer, so he advocates Advil. I'm just kidding. You know, I think that Advil works better as a pain reliever, and I would probably strongly recommend Advil or Motrin or any of these NSAIDs if they're not an orthodontic treatment, but if they are, we're going to just stick with Tylenol. So that's the first modality that we all have to encompass when we're doing any type of acceleration, or we're wanting to see things becoming more reliable through our treatment. So the biology of tooth movement starts with a force. There's the red line on the bracket, applying force, and that pressure creates vascular constriction, and you're going to start to get fiber disorganization, decreased cell proliferation, and fiber production. On the tension side, you're going to get cell proliferation and fiber production. And so as we're pushing on this tooth, we're going to be creating change to the bone. And that change is the biology of tooth movement. And I think we're all pretty familiar with it, but if not, we're just going to go through it real quick. So you have frontal resorption, that's the pressure side, that's the vascular constriction, and that's where the macrophages, you know, the things that start to resorb, or the osteoclasts start to come in here and start to break down the bone. And then when the teeth move into the right place, then it starts to stretch on the fibers, and that creates the tension side, and that brings the osteoblasts into place, and they start coming in here and start creating some new bone to form the stability for the movement of the new position for the tooth is going to be. And then the red area is if the force is a little bit too heavy, if it's too high, then we can get undermining resorption. And this is where we get vascular obstruction, and this is where we start to see slowing down of tooth movement. So if we're not using a biologic force to move teeth, then we see that the bone starts to get almost like what's referred to as a zone of high elimination. And it's a necrosis cell-free zone because there's no vascularity in that area, and it's basically too much pressure. So we really want to be careful that we're not, in the world of orthodontics, especially in accelerated orthodontics, we're not increasing the amount of force. We're going to keep the same force level, a biologic force level, so the body responds favorably and doesn't create any negative side effects. Some of the really cool things about accelerated orthodontics is that by getting people's treatment done sooner, ahead of schedule, we're reducing all kinds of potential negative sequelae that we've had to face in the past. So micro-osteoperforation, or manual osteoperforation, works with the patient's own biology by stimulating a cytokine response, allowing the patient's bone to remodel in a faster and a more predictable way. In orthodontics, we know that the rate of the bone remodeling determines the speed of the tooth movement. And so therefore, if we can increase the rate, then we can also increase the tooth movement and therefore decrease the overall treatment time. NYU study showed incorporating perforation into a patient's orthodontic treatment that they could increase the treatment by 2.3-fold, and it could lead to 40 to 50% reduction in treatment time. That particular study wasn't looking at it over the full length of treatment. It was looking at it over a month time frame, and they did see from a split mouth study that on one side of the mouth versus the other, the side that had the perforation, it moved almost 2.3 times faster. So it's pretty significant. That's the landmark Alpan article that I'll make reference to in the future presentation. So this is just another slide showing about bone remodeling, and we've got macrophages and pre-osteoblasts and osteoblasts and osteocytes and blood vessels and monocytes and pre-osteoclasts and so on and so forth. And so resorption, leads to reversion and then formation and then mineralization. And so that process of bone remodeling is something that we have to be sensitive to as we're moving teeth around, because that's always the basic fundamental cellular process that's happening. And so what we're now doing is we're going to now apply things like perforation or maybe other techniques to cause the biology of the bone. I'm now referring to it as osseous modulation. So we're now modulating the bone, modulating the osseous response by not changing what we're doing orthodontically. We're getting a different response biologically, and therefore we're able to reduce treatment time and in some situations even reduce sensitivity during treatment. So again, decreasing the cytokine response decreases tooth movement. So we know that if we introduce an NSAID, we're going to get decreased tooth movement. We're going to get an increased treatment time. And there's tons of studies there, and those are all kind of making references to what those studies came up with. But basically, bone remodeling is the basis for orthodontic tooth movement. Cytokines play an important role in the orthodontic tooth movement, and the application of anti-inflammatory medication to decrease that tooth movement. So with perforation or osteo-perforation or osseous modulation, we're going to create bone injury. We're going to increase the amount of inflammation. We're going to increase the cytokine production. We're going to change the rate of bone remodeling. And in a sense, we're also reducing a little bit of the bone density. And so by doing that, that's where we start to see the biologic response. So different modalities in accelerated orthodontics. They're doctor-controlled accelerated devices. This is called corticotomy or wilcodontics. It's a little bit more invasive. We usually are laying full thickness flaps and corticating or decorticating the bone, making dimples, and then many times they'll even pack bone in there and then lay the flap down and sew it up. And it's probably the most invasive, the most time intensive. It requires patient recovery time. It's the most cost. I think the lowest I've heard is $5,000. The most I've heard is $15,000 for one of these procedures. That's independent of the orthodontic fee. It requires extensive training from the clinician, and there are some possible negative sequelae, some attachment loss, some bone loss. Some of the periodontists are advocating it in patients that already have some periodontal problems, and they're going to be going in there and doing surgery. So if that's the case, they can do it together. Piezo surgery is a little bit less invasive because you're not decorticating, but you are doing corticotomies. You're cutting into the bone and trying to get the body to respond faster by creating a tremendous amount of inflammation. It still requires a flap. It requires a patient recovery time. There is a higher cost, but not as much as corticotomy. Requires extensive training from the clinician, whereas micro-osteoperforations or manual perforations are micro-invasive. There's no patient recovery time, maybe 24 hours. Low to no cost to the patient, minimal training for the clinician, minimal cost to doctor, minimal cost to the patient. The thing that stands out the most for me is that there's going to be very little negative sequelae. They're going to get a little hole in the gingiva, and then that's going to heal up in 24 hours. And that's pretty minimal compared to some of these other procedures. And then the cost is dramatically less. So these are the doctor-controlled manual osteoperforation devices. This was the first version. It was the single-use version. And basically there was a depth measuring tool on the end of the driver. And there was a little light that would light up and let you know that you've reached the depth limit. We don't have that anymore. That's not available, and we've moved on to a reusable handle where you can take the two pieces apart, and the tip is disposable. And each tip is a one-time use for each time that you use it inside the patient's mouth. Not for each hole, but for each appointment time that you're doing the perforations. So this is also a depressible sleeve that will give you a measuring number based on how much depth you've been able to create into the bone. And then this piece comes off, and then the handle is sterilizable. The automated device is now really, really cool. Accelerator, and it's great. It takes out a lot of the work. It has a contra angle to it, and so you can actually sterilize the tip, the end of the unit, and then you can replace the individual burrs on a per use basis. It definitely makes a lot of saving time and makes it a lot easier for the practitioner to apply the perforations, because you're not sitting there actually having to turn the device. You just use the on-off or forward and back buttons. Micro-osteo-perforation should only be created with devices specifically designed for the perforation. Substituting devices should not be used since they are not FDA approved. When you purchase the device, you also purchase that protection. That you're using a device that has been FDA approved for that specific purpose. So I've had many people tell me, oh, I just use a TAD, or I just use a round burr, or I just use this, or I just use that. And what they're doing is they're opening themselves up to liability, since those procedures are not considered FDA approved. You want to kind of stick with the device. And when you look at the cost of it, I really don't think that the cost prohibits you from being able to use the device. And in fact, it's very favorable, probably the most favorable. Patient-controlled light-activated acceleration. This is another device that's out there. This is the original unit. It was an external device. It sat on the outside of the face. They now have an intraoral device that shines light. You can see the little girl there is lighting up. And basically, it's working on light activation or photobiomodulation. It works in the 800 to 1,000 nanometer wavelength. What it's basically doing is it's enhancing the tissue metabolism, increasing ATP production. So the light is actually stimulating the cell. Within the cell, the mitochondria begin to get really going, and they start to metabolize everything faster, and ATP production is produced dramatically greater. And so therefore, the process of the osseous modulation is really what we're looking at occurs. Device is with a headgear or intraoral, requires patient to self-administer 20 minutes a day, and so it does require patient compliance. And Biolux, I think, is the company that's offering this product. I've heard some mixed reviews on it. I don't myself have any experience with it, but I just wanted to share that this is something that's out there. This is another patient-controlled low-frequency vibration device. This I do have some familiarity with. This is a rechargeable device. Requires patient to self-administer for 20 minutes a day. It relies on patient compliance and can cost the patient anywhere between $800 to $1,200, although the prices for that have been coming down as the market has become a little bit more competitive. And then there's a patient-controlled device that's high frequency that was just launched and created this year, the vPro 5. And so it's not being sold as an acceleration device, but if we see that it enhances the way that the aligners fit on the teeth, then we're seeing that their potential is for aligner treatment to move maybe a little bit faster, or we could have better retention. So animal studies. What are the animal studies? Let's look at what they were originally testing. And there's a rat jaw, if you're not familiar with it. And what they were looking at is applying force to the teeth in the rat jaw and seeing how it responded versus a control, so no force application, the B orthodontic, force application where you can see the separation of the teeth, and then orthodontic movements or force application in conjunction with perforations, and you can see how much more space was created with the same amount of force in a similar type of an environment with a rat jaw. And then the expression of cytokines. What we're looking at here is multiple cytokines. So these are all the various different cytokines that were looked at. And the yellow is the bar that shows the ortho with perforation, and the white is just orthodontic movement. And so you can see that almost in every situation, well, maybe not that one, there was a pretty significant standard deviation difference that makes it statistically significant that there was, more increase in the overall expression of cytokines in the area with the perforation group versus the group that just had the orthodontic treatment. And it's showing it on multiple cytokines that were measured. So it's pretty cool, pretty significant. And then these are some scanning micrograph views of the control bone versus the orthodontic treatment bone versus the ortho-perforation. And you can see the amount of proliferation, the changes that are going on there. You can see that there's a lot more going on in the perforation group. And then you can see the same thing with the microscan of the bone, where you can actually see what's going on there, and you just see more cellular activity in the ortho with perforation. So we can do that with rat jaws, right? We can't do that with human jaws. The control, the orthodontic, and then the ortho with perforation, and what you can see is the cellular change and the activity that's going on there is dramatically different. And this is basically a periodontal ligament here. You can see the P stands for periodontal ligament, R is for the root, and the B is for the bone. So if you look at the control, where there's the root and then the periodontal ligament, the cellular change that's going on there is very, very small. And then when you look at the orthodontic tooth, it's a bit bigger. And then when you look at the ortho perforation, it is dramatically different in how it's responding. So when they looked at canine retraction and they looked at the control versus osteo-perforation, they saw a dramatic difference between the control and the osteo-perforation in multiple areas, in the upper third, the middle third, and also in the lower third. So human studies. This is the one that I was referring to earlier. This is sort of the landmark paper that was published in the AJO. It was published by Alpan and a few other people on the team there at NYU. And the study utilized the perforation device and created micro osteo-perforations, reducing treatment time by as much as 62%, or a 2.3-fold an increase in velocity. So bodily movement was shown, there was no tipping, and the patients reported little to no post-treatment discomfort. And so this is the split mouth study that I was referring to earlier, whereas on the right side, they're creating a force system with a temporary anchorage device, a night-tie closing spring, and a root helper to try to retract the teeth. And they did exactly the same on both sides, and they measured the force on both sides with the spring to make sure that they were creating the 150 grams of force that's needed to retract the tooth. And so they tracked it over a month, and what they found over 30 days or 28 days is that the side that had the perforations, they saw almost 2 times the amount of space opening versus the side that didn't have the perforation. So the right side didn't get as much retraction of the canine as the left side did. So it's the same mouth, same person, just one side of the mouth had perforations, the other side of the mouth didn't have perforations, and so the side that had perforations, we're seeing a greater amount of space opening mesial to the cuspid, or that the cuspid is distalizing faster. And so that study, when they measured the cytokine levels in the control group versus the osteo-perforation group, they found that in the first day it was dramatically higher, and then it actually began to decrease over time, but it still stayed high even as much as 30 days later. It was still almost double the amount of cytokine level, and that's in all the groups that they looked at, which is pretty cool. So because the cytokine activity decreases over time, osteo-perforations must be repeated every 12, and sometimes we've even gone as far as 16 weeks in order to maintain the inflammatory response. Some of the new things that we're doing is combining some of the perforations with vibration. So maybe we'll perforate once and then move forward with vibration. But if we're just looking at perforations, then we're typically going to be doing it every 12 to 16 weeks. These are a couple articles that I wrote. One was in Orthodontic Products in May of 2014, and the other one is in Orthodontic Practice, and this last issue in September just came out. So this is my most recent article. It's a review of accelerated orthodontics. There is a continuing education feature to it, but it kind of gives you an overview of some of the things I'm talking about today and what my experience has been involved with accelerated orthodontics and how I apply it and my history with it. This article was published in April of 2014, and it was printed in the AJO, and everyone agrees. Orthodontists and patients alike are all interested in the same thing, techniques that can accelerate tooth movement so we can get patients out of orthodontic appliances and Invisalign braces as soon as we possibly can so that they can move on with their life and into their retention phase. So manual osteo-perforation technique, what we want to do is we first want to evaluate what's going on with the patient where we're going to be perforating. So we take a look at some panoramic x-rays, maybe have some PAs in the office. Either way, they're both fine. We just want to make sure there's no supernumerary teeth, there's no pathology in the bone, nothing going on there that if we start perforating into that area that it's going to create any other problems. So we do an evaluation, and then we rinse the patient's mouth. We get it really nice and clean with chlorhexidine. Usually we're going to do 2 rinses for 1 minute each. Sometimes we do it a little bit less. Sometimes we'll do it for a little bit more, depending on how the patient follows or hears the instructions. But typically we try to get them to rinse with the chlorhexidine. And then we anesthetize. On the anesthetizing part of it, before the perforation, we use a combination of a regular topical and a very profound topical. Sometimes we will have to use a local, but for the most part we can use some topicals. Either way, whatever you're comfortable, whatever your comfort level is, and also what's going on with the patient. So if the patient is feeling hypersensitive with the regular topical, the benzocaine, and then the more profound topical, with the, then what we're going to do is probably pull out the syringe, and we might end up doing some local infiltration. I've never had to block a nerve for this procedure. So the amount of pain and sensitivity that's created is really not a lot, but at the same time we don't want the patient squeamish along the way. So then we go ahead and we apply the perforations. We're just screwing in the device into the bone, and we'll show you kind of where and how. But basically, I'm ranging between 3 to half a millimeter, 3 millimeters to 5 millimeters in depth. And so, whenever I'm evaluating the treatment, I'm always sort of evaluating what's going on radiographically, and I'm looking at the patient's teeth and bone. And this is just a model, and you can see here that underneath the roots, that's where the nerves and everything and arteries and blood vessels are going. We're really not going down that far. We're going to be maybe a little bit towards the the apex of the bone, or maybe 3 to 5 millimeters apical to the crest of the ridge of the bone. Going down below that, you're going to be really far into the vestibule, and it's going to be a little bit difficult to get down there. And so we're pretty much staying. We like to do most of the perforations in attached tissue. Sometimes we might get one perforation in the mucosal tissue. So we clean the mouth, chlorhexidine, two rinses, we anesthetize, then we perforate. The perforations are determined usually by the soft tissue thickness of the patient. We really want to penetrate the bone about 2 millimeters. We're really not looking to go deep into the bone. Going into medullary bone isn't really what's going to create the inflammatory process. It's breaking the cortical plate, creating a little bit of microfracture that really tends to give us the biggest bang for the buck. So like even when I've made perforations that are 7 millimeters deep, I didn't find that those people responded any better or different than the patients that I perforated 5 millimeters. And again, 3 to 5 millimeters is range. And so as I get closer towards the ridge or towards the crown of the teeth, I'm probably at 3 millimeters. And as I get closer towards the apex or further down into the vestibule, I'm going to go maybe closer to 5 millimeters. Now, if someone has very thick tissue, then I'm probably going to plan for maybe a little bit more, maybe 5 to 6 millimeters, maybe 3 to 4 millimeters. And then if they have very thin tissue, maybe I'm going to be between 2 and 3, or between 4 and 5. Depending on the location in the mouth. So the compounded topical, I did print it out here on the slide. It's 10% prilocaine, 10% lidocaine, 4% tetracaine, and that's one formula. And then there's another formula that has lidocaine, tetracaine, prilocaine, and phenylephrine. I find that the one with the phenylephrine is a little bit more profound. There's a few different kinds out there. You have to usually buy them from a compounding pharmacy. And if you need, assistance and guidance on where to get that, your rep can help you with that. But basically, it's a pharmacy in Woodland Hills, and they create a couple different formulations. The technique. So it's a single-use device. You can go 3, 5, or 7 millimeters depending on where you are. Typically, I'm staying between 3 to 5. We rotate clockwise to apply the device, and then we rotate counterclockwise to release it. The one that I'm using now, majority of the time, is the reusable handle and the automated one. So it's pretty much the same technique with the manual ones, except for the automated ones just make it a little bit easier on your hand and don't put as much stress on your wrist and allow you to get through the process a little bit faster. So some considerations when you're doing this. Most patients require 1 to 2 perforations per case. Complex cases may require 3. I, as of yet, have not had more than 3 treatments per patient. 2 to 3 micro osteo-perforations are recommended mesial and distal. The osteoclastic response, what we're finding is as far as 6 to 10 millimeters away from the site where we place the perforation. So just because you're perforating in one area doesn't mean that you're not having an effect in another area around that. So there have been times where I've skipped over and done every other tooth, and there have been times also where I'm doing 3 perforations between each tooth, and then sometimes I'm only doing 2 perforations between each tooth. It just kind of depends on to what extent I really want to create the biggest effect, or maybe not. Maybe there's some areas where I don't want the teeth to move at all. So maybe, like, for example, like if I want the molars to stay exactly where they are, I won't perforate around them at all. I'll just perforate in the anterior. Or vice versa. Maybe I want the anteriors to stay exactly where they are, and I just want a lot of movement in the posterior. I want to mesialize some posterior teeth so I can close some spaces without retracting the anteriors and dishing in the profile. And so then I might just perforate in the posterior and not perforate anything in the anterior. So I can actually use my perforation as a way to help support my my anchorage concept. So for acceleration, I'm going to perforate around the rate-limiting movements. It's usually going to be the tooth that's the most difficult, or multiple teeth, or a quadrant of teeth where I'm having difficulties. Depth selection is going to be typically in the anterior 3 millimeters, 5 to 6 millimeters in the posterior, and in the palate I will go 7 millimeters. And the reason why is because the thickness of the tissue is dramatically greater. And of course that ranges in different, biotypes and ethnicities and genders. Osteoclastic effects peaks in 24 hours and remains elevated for 12 weeks. We've even seen as high as up to 16 weeks. So typically that's why 1 to 2 treatments is all you're really going to need for most of the patients. Benefits of perforation, patient benefits. It's minimally invasive. It's performed chairside. You can use it for any type of orthodontic treatment, aligners, braces. It does release difficult movements. It accelerates treatment, increases treatment predictability. There's no patient recovery time needed. It is a doctor-controlled, and there is no compliance needed. Saves time, less office visits, which means less time off work or school. So I think patients really like that. They like not having to come in as much. Practice benefits. What does that do for us? Well, it's cutting-edge technology. It's offering something that most people are not. It's increased treatment acceptance because patients want treatment done faster and shorter. It's going to attract new patients because of that. And then it incorporates, in some scenarios, a premium, so a little bit of a higher fee, to get the treatment done faster, and reduce patient burnout, increase predictability of orthodontic mechanics. And so that's some of the things that I'm finding, that even if I don't get finished faster, if I can get my result more predictable in the reasonable treatment time that I originally estimated, I win in the patient's eyes. And so that's what I'm trying to go for, is a combination of really those 3 things, predictability, reliability, and reduction of treatment time. And to me, I think reliability and predictability are just as equally as exciting, especially in the really difficult cases, which I'll show you a couple of those. And then I'll show you a bunch of easy cases too, which are all a lot of fun. Most people call those the low-hanging fruit, or the profitable cases. To me, I call those boring. But, but we'll show you the boring cases too. How many manual osteo-perforations? So we said perform 2 to 3 perforations depending on the proximity of the anatomical structure. So you can see my little yellow dots. I'll either do 3 in a vertical, or maybe 3 in a triangular pattern, or maybe just 1 in a certain area. Now typically I've been kind of staying away from the frenum here in the middle of the upper incisors or in the lower. If there's a frenum attachment that comes in kind of high in any other areas, sometimes I'll stay away from those areas. I don't really want to perforate through that. So these yellow dots are just kind of showing you samples. Most of the time, like we said, we're in the attached tissue. Sometimes we might end up in some of the mucosal tissue. How deep to perforate? So there's 3 in the anterior, 5 in the posterior, 7 millimeters potentially in the palate. This is a closer look of the anatomy here. This is what it looks like after a perforation is done. So it just looks like a little bit of a small little hematoma, or a little incision, but very, very small, and then those usually heal up within 24 hours. Definitely on the palate, the depth is going to have to be much greater, and again, it also depends on the thickness of the tissue. And so really what we're looking for is about 2 millimeters to go into the bone. And this is another close-up. This is not right after we perforated, but maybe like a few minutes after. And so you can see how it starts to happen is it starts to kind of seal up a little bit on its own. You can see the circle there is the actual sheath pushing down on inside to give you the depth. So that's the depth measurement, and then the actual hole in the middle is the perforation. So there's the sheath right there, and you can see what it does is it usually creates like a little indent into the gingiva, and there's the perforation right in the middle. So post-treatment instructions. Patient may experience some tenderness around the treatment sites for anywhere between a day or two. Typically, I find it's not two. This sensitivity is similar to that of an orthodontic adjustment. We strongly recommend, in fact, we really make a big deal about patients staying away from NSAIDs, because why are we going to do this extra procedure to increase localized inflammatory process, and then they take something intraorally and it affects that inflammatory process in the alveolar bone. Micro-osteo-perforation may be repeated 10 to 12, sometimes even as much as 12 to 16 weeks in between appointments, and then post-treatment instructions are always going to be the same to make sure that they're taking only Tylenol. And, sometimes we'll actually have the patients do a little saltwater rinse for maybe a day or two after the procedure too, because that's also been found to help keep the mouth clean. Maybe it's an old wives' tale, but I think a lot of people that do surgery still advocate that. Benefits of using perforation with aligners. So when we start incorporating acceleration into our Invisalign treatment, what we're going to see is that we can increase the appointment intervals because the patient is going to change the aligners a lot faster. I know some doctors, Dr. Shipley specifically, who's changing out his aligners every 3 days. I know some people that are changing them out every 5 days and some that are every 7 days. But most of us are definitely almost half or greater than what the normal requirement is. So instead of 14 days or 2 weeks, most of us are usually at 7 days. Some people are still only doing 10 days, but what starts to happen is if, let's say we go to a 7-day cycle for each aligner, now I'm giving them 4 aligners, they're changing them out once a week and they're coming back in a month. That's a much better patient experience than giving them 2 aligners, they change them out every 2 weeks and come back in a month. Because the patient doesn't like the aligner after a week. They love getting a new fresh aligner. So my acceleration patients with with Invisalign aligners, they love it, and I love it too because I can sometimes give them 8 or even 10 or sometimes even 12 aligners at a time, and I say I'll see you back next time, and then we'll give you more aligners, and maybe we'll see if we're ready for another perforation. You're going to avoid refinements or reduce the number of refinements. You're going to avoid mid-course corrections, expedite treatment results, again, keeping things more reliable. You're going to reduce aligner lag, so things are going to track better. You're going to increase your treatment predictability, and you're going to facilitate challenging aligner movements, especially your extrusions, your big rotations, and so those things will start to become a little bit more reliable. It'll reduce your overall chair time. It will increase a little bit of chair time when you have to do the perforations, but the overall reduction in chair time will definitely be an increase in your profitability. So I have a couple of different ways that I'm applying the perforations, and that's one is proactive, the beginning of treatment, right when they first get started, or reactive. They're already in treatment, they want to get things done, they're a little bit burnt out, and they're asking me, Doc, when is this treatment going to be done? I really want to be done. I really love you. I love coming here. I always get I'll still bring you cookies, but just get these darn braces or these aligners off. I want to get into normal stuff. So reactive acceleration is done, and actually I find there's a higher acceptance of acceleration is when the patient's already in treatment and they just want to get done as quickly as possible. So proactive, we'll do anywhere between 5 to 7 day intervals from the start. We can give them, usually my first aligner I just give them 1 or 2, and then I kind of slowly dole them out. And then once I feel confident, usually after 2nd, 3rd, or 4th appointment, I'll start to really ramp up the numbers, anywhere between 6 to 12 aligners. So then I'll schedule anywhere between 6 to 12 weeks, depending on how I'm doing it. And then I'll start to look at when I'm going to be doing my next acceleration. So I instruct the patient to call the office if aligners don't fit the same as the initial visit, and then record dates on the aligner bags and instruct the patients when to change them out. So we give them very clear instructions as far as dates, and we always have people change out their aligners in the evening before they go to sleep. And it seems to be working really, really well. And so aligner patients with perforation or any acceleration works great. Reactive acceleration, we're going to basically bring the patient back to the best fitting aligner, and then we're going to perforate mesial and distal to the non-tracking teeth, and then we're going to deliver 4 to 8 aligners, and we're going to schedule a follow-up visit in 4 to 8 weeks. And we may dimple aligners or use any auxiliaries as needed, buttons or elastics or things like that if we're correcting rotations or class 2 or class 3 relationships. But again, this term proactive versus reactive is something that's very real, and the pricing is also a little bit different. For proactive patients, we tend to charge $250 per treatment, and for reactive acceleration, I have charged as little as nothing. Sometimes if I have a lateral that's not responding, or I have a tooth that's not quite doing what I want, or a quadrant that's not moving the way that I want, I might just decide to pull out my device and propel or perforate them, at no charge. What does it cost me? $150 or something like that. And then their treatment gets done instead of in 6 to 8 months. I'm getting them done in 4 more months or 5 more months. And so, if I can knock off time for the patient and for me, it just makes everything more efficient and better. And so these are the 2 different ways that I'm applying perforation, and it can also be applied towards vibration. So manual osteo-perforation with brackets, we're going to see similar things like expedite treatment results. The cases are going to stay on track. The mechanics and goals are going to be more reliable and predictable. We're going to facilitate challenging movements. In my opinion, sometimes things that were extremely difficult or almost impossible are now achievable. And then we're going to reduce chair time, we're going to increase profitability, and we're going to be promoting accelerated orthodontics to the patients in the community. So if they're walking around with braces, they're like, I call them a walking billboard. They're literally telling everybody about how great the experience was and how quickly they were able to get things finished, and so it's kind of becoming a little bit of a buzz. You can treatment plan more difficult movements with a much more reliability and predictability than you can without. And of course, I'm using some other techniques, and we'll kind of talk a little about that, some of the other biomechanics that make things more efficient. But proactive acceleration, you can maintain the same biomechanics, decrease time between appointment intervals. And so when you're doing it on a proactive way, with braces especially, you have to start seeing the patients a little bit sooner on every 3-week basis. You can definitely level and align faster with more predictable treatment outcomes. We're still perforating mesial and distal to the sites and only required in areas of difficult movements. So if I've got no rotation in an area, or I don't want a tooth to move, or there's nothing that I'm looking to try to make a change, I won't perforate in that area. Accelerate when arch wire is engaged, and where perforations can be made 12 to 16 weeks apart. So reactive acceleration is a little bit different, and part of the reason why is because we don't have time in our favor anymore. So we're going to maintain the same biomechanics. We're not going to change the force level, but we are going to add some auxiliaries. So maybe we might add some more power chains with buttons for rotations, or maybe if we're trying to close a space, instead of just pulling from the labial, we'll pull from the lingual. We'll do a bidimensional force application. We can decrease time between appointment intervals by as much as 2 weeks, and we're going to resolve difficult movements holding up the finish, and we're going to perforate mesial and distal to the sites, and it's really only required in these difficult areas. We're going to accelerate when the arch wire is engaged, and perforations can be made at 10 weeks apart. So we start to shorten the intervals of perforation so that we can start to see a greater amount of change in a shorter period of time. So if you've got a type of malocclusion, you're treating things orthodontically, all these options, you can use some type of perforation or acceleration to make the treatment finish faster, more predictable, and a little bit more reliable. So these are just various choices or options. So let me show you some sample cases of patients that were finished. And so this slide here says picture perfect selfies delivered ahead of schedule, and so that's one of the marketing pieces there. So high frequency vibration. Let's look at this new device. It's called the vPro 5. It has a little mouthpiece device. It has a USB flash drive preloaded with software. So that's that right there, and you can teach yourself exactly how to use the machine, the various connectors and things like that. But it's pretty easy to use. So the device looks just like this. There's all kinds of instructions on how to use it. It really just functions for about 5 minutes per use. And so it's taking into play the concept that if it's a higher vibration, you can use it for a shorter period of time. And so there's different indicators, different lights here on the device. There's a blue, green, and red, and depending on if it's continuously blinking or 3 blinks, it tells you whether it's a 5-minute cycle is completed or the device is fully charged. And so you can look up what these various colors look like, and it also indicates, for example, if you've got a low battery or if the device is plugged into the charger, and so it tells you exactly through the light system what's going on. And when you use the system, you want to connect to the software and register that you're actually being used and you're using it. You want to assign the device to the patient. So every time you give a device out, you have to use and go online and assign the patient. Enter the new patient details and customize the patient ID, and you want to add them into your usage summary. And so this is just kind of walking through the software on how exactly it works and how you would assign a patient to that software so that they can be tracked properly. And then what it can do is give you a little bit of a summary of the usage, of how much it's been used or not used, and then you can have some feedback or compliance discussion with the patient. So some peer-reviewed science around vibration. So this was a study that was done in 2010, Journal of Musculoskeletal and Neuronal Interactions. Is bone formation induced by high-frequency mechanical signals modulated by muscle activity? And the conclusion showed that bone can differentiate between various frequencies of vibration in terms of remodeling. Subjects exposed to high-frequency vibration showed bone formation rates of 159% greater than controls, and bone formation rates in low-frequency vibration subjects, 45 Hz, were not statistically different than controls. So the structural benefits that bone can gain through exposure to vibration are very apparent. So there's the graph that shows you the impact on bone volume, high versus low frequency vibration. And so they were showing that the high frequency in this study was dramatically more beneficial. In this study, Alpan showed the osteogenic effect of high frequency acceleration on alveolar bone. And in his conclusion, the experimental group had significant increases in bone quality over the same period of time compared to the sham or the control groups. That's kind of what this bar graph is showing you, and also what the slides of the bone changes are static versus vibration. And so in the vibration group, again, we're also seeing a little bit more change that's going on there. Localized high frequency of force of low magnitude is able to induce osteogenic activity within the surrounding bone. High frequency acceleration or vibration caused nearly twice as much bone remodeling as low frequency vibration on a 5-minute per day application. And that was in April 2012. In 2016, in the Angle Orthodontist, vibratory stimulation increases interleukin-1 beta secretion during orthodontic tooth movement. And so they started to measure that, and they found that in the experimental groups, they were all greater than the controls, and they were statistically significant. So 15 adult subjects, typically like 30, but 15 is half of the ideal N, underwent bilateral extraction of first premolars and canine distalization. Experimental canine was vibrated at 125 Hz with an electric toothbrush. So not necessarily the vibration device that we're used to, but an electric toothbrush. Cumulatively, experimental teeth moved 61% more versus the control teeth. I have a feeling that was kind of uncomfortable with that electric toothbrush. But after 2 months of vibration, the interleukin-1B jumped to approximately 3 times higher levels than observed in the T1 or the T2 times. So in combination with orthodontic forces, high-frequency vibration stimulation appeared to increase bone resorption activity, accelerated tooth movement, and greatly enhanced secretion of the inflammatory markers. Another study in January 2016, also from Alpan at NYU, showed that high-frequency acceleration is a therapeutic tool to preserve bone following tooth extraction. And so high-frequency acceleration accelerates bone healing in the tooth extraction site, and so that's what they were looking at in this study. And the application of the high frequency in long term preserves alveolar bone, and high frequency acceleration increased bone healing through intramembranous ossification. So this is a pretty recent study. So let me show you some actual cases where people finished faster using perforation, and let's take a look at that. So this treatment plan was aligners with manual perforation. And you can see that this patient started with, some crowding, upper and lower arches. We had a class 2 on the right side. And by the time they were done, 3 months progress using 3 manual osteo-perforations. They're much better on their class 1 on the right side. Lower incisors are all resolved. Upper crowding is resolved. Ended up taking out a tooth on the upper right side, so I mean, pretty significant result. Patient was in a hurry, but requested clear aligner therapy. The treatment began using a vibration acceleration method, but after several attempts was unsuccessful in getting the movements completed as quickly as desired, and manual osteo-perforation was then introduced around number 5 to complete the required movements. And this was done not by myself, this was done by Dr. Keith Wong. Pretty nice result. Here's another patient. Started out as a class 1 crowding, ectopic position of the upper right lateral, pretty severe crowding. And it was with aligners and manual osteo-perforation. So this took 10.5 months with 33 aligners and 3 osteo-perforation applications and no refinements. So first off, just to get no refinements, I think is quite significant. And then to get it all done in 10.5 months, I mean, some of these cases when I first started doing Invisalign, that might have been a 2-year case. And even at the end, we may not have gotten the midlines lined up and the resolution as well. So not only am I seeing reduction of treatment time in this patient's treatment, but I'm also seeing a better result in a shorter period of time. This is a Shipley case. These are 3-day intervals, so this is going a bit faster. This is a mild class 2 division 2 case. Upper and lower crowding with 60% deep bite and negatively inclined upper incisors and rotation of the upper left lateral incisor. So you use the aligners with the perforations. And in 6 months, using only 1 perforation and on 3-day intervals, he's able to rotate laterals, resolve crowding on the lower incisors. So it's pretty impressive. Something like this without perforation would definitely be a year, and with just a little bit of small amount of non-compliance could easily go to a 1.5 years. Class 3 case, not treated by me as well. This is by Dr. Nick Azizi, and you can see we've got a slightly anterior open bite, edge to edge in the anterior, aligners and manual osteo-perforations. This was 5 months of treatment only using 2 perforations, and you can see how well he was able to close the bite, close the spaces, resolve crowding, improve the bite relationship. So I think it's a pretty cool result there. You can even see that some of the tissue response actually improved by some of the more favorable tooth relationships. Once teeth are occluding in the right way and you don't have all these forces that are creating problems to the perio, you don't see as much recession. So I always like it when we're done with ortho that we actually see improved recession areas. So 5 months using 2 perforations, 20 aligners, and no refinement. Pretty significant. I don't think that could be done without the perforations. Here's another anterior open bite case by Dr. Nick Azizi. 16 months using the perforations, so you can see it's almost a bilateral cross bite with an anterior open bite, and you can see that this really finished out pretty nice. And then here's another case, 7 months using 3 manual osteo-perforation applications. We got a narrow maxilla. You can see almost a V-shaped maxilla to begin with, and then when we're done, we've got a nice U-shaped arch. Distal root tipped on the centrals, so I mean that's difficult to get those upper centrals unraveled in 7 months. I mean that typically, in the past I'd be talking about maybe 1.5 years or something like that, maybe 1 year to 1.5 years. But I think a pretty nice result in 7 months with only 3 perforations. This was a treatment that was done reactive, so the patient was already in treatment before they decided to do the perforations, and so as things weren't quite going the way that they wanted, they decided to jump in the perforations. And this is 6 months with no refinements. So I don't know exactly what the time was where he didn't have anything, but I have a feeling it was maybe only 1 or 2 months without anything, and then they started the perforations. But pretty nice result in a very short period of time. You can see the resolution of crowding on the lower arch, the widening of the upper arch, and the resolution of the overjet of some of the anterior teeth. And this is another case, also by Nick Azizi, 10 months using 3 perforations, pretty significant changes to those laterals, and kind of closing a open bite tendency there. Here's showing you a patient that was perforated, and you can actually see the perforations on the slide, and you can see what was done here, just closing up some spaces. This is just 8 weeks using 1 perforation. And again, this is a 3-day cycle of changing aligners. Here's another one, lower anterior crowding, aligners and perforation. 8 weeks using 1 perforation, so pretty significant result. again, also on a 3-day cycle. Here's another patient, little deep bite, crowding on both arches. You can see in 3 months using one perforation how well that was resolved. And again, that's changing him again on a 3-day cycle. Here's another patient, also 3-day cycle, lower incisor extraction, a little bit more complicated. 51 days with 17 aligners and 3 refinement trays and 1 perforation application. So there you can see the end, what it looks like with a lower incisor extraction result, and then there's the uprighting of the roots, and you can see it all radiographically. It's with the CBCT scan. And here's another patient with a lower incisor extraction, 5 months with 1 perforation, and you can see how nicely that closed. So it's pretty significant results when we start applying these perforations and our vibration. So Proactive, this is right from the beginning. He started, it took only 4.5 months of treatment with 1 perforation. And you can see a nice resolution of that cuspid position and improvement of the midlines and even improvement of the deep bite. And so typically to get improvement of the deep bite, with Invisalign, that usually was a lot longer time frame than 4.5 months. Diastema, space closure, 4 months using 1 perforation. Didn't quite get the midlines as good as the last one, but pretty nice result in a very short period of time. Here's another case, similar. A lot of crowding resolved, 5 months, aligners with perforations. Here's another patient, Proactive, 8 weeks using 1 manual osteo-perforation application, and this is changing the aligners every 3 days. So you can see the lower incisors really got unraveled. Midline stayed the same. We did get some improvement on the upper arch alignment and closed up some spaces that came back, some relapse spaces. That was by Dr. Shipley, and this is also another doctor, Dr. Miraglia. This is 9 months of treatment using 24 aligners with no refinements. You can see really nice improvement of the overbite and the overjet, coordinating of arches, resolution of crowding, upper and lower. Here's another patient, 6 months using 2 perforation applications. This is another patient with a lot of recession, a lot of bone loss. This one was done in 9 months using 2 perforations, and they were changing out the aligners every 7 days. So nice change in the bite on both sides, and nice improvement of the anterior relationships and resolving of crowding rotations. Another case, class 1 crowding, 6 months using 2 perforations, and they were changing out the aligners every 5 days. And so that's kind of what I was telling you before. Some people are at 3, some people at 5, some people at 7, some people at 10. Obviously, a line recommends 14 days. We all know that the force level after 10 days is dramatically reduced. And so there are some people that just increase the number of aligners and decrease the amount of movement per aligner, and they do it that way. I still don't think that they're getting the same type of results, predictability, and reduction in treatment time as when we're incorporating acceleration. Here's another scenario where I resolved a little bit of a deep bite and some crowding, 3 months using 1 perforation and on a 7-day aligner sequence. So here are a few cases using osteo-perforation with braces. And so here's crowding, class 1, not too complicated, but you can see a really nice change in 4 months only using 2 perforation applications. Here's another patient where it was a combination of SureSmile and manual osteo-perforations. It took 7 months using 3 perforations, applications, and closing 11 to 12 millimeters of space. So, utilizing something like this, most probably with temporary anchorage devices and smart mechanics, sliding mechanics. This was probably not done, for sure was not done with Invisalign. This was SureSmile braces. And I don't think that is something that could be done without doing perforations and TADs and things like that. And in the past, our only choice was really to just use implants. So this is a really nice case to show that we can offer patients now maximum space closure without any negative sequela in a reasonable treatment time. Another scenario where we were closed in a dentulous space, did it in 11 months using 3 perforation applications with braces. This was done at NYU. You know, like I said in the past, this was just something that we didn't do. We just placed an implant there, and so now if we can offer that to our patients, I think that's a pretty nice treatment plan for most patients. There's another scenario where we're closing either a bicuspid space there, and we're basically protracting the lower molars. This was 2 months of progress. So from here to here was just 2 months using only one perforation application. So that's the only time that they actually used the perforation to help in this situation, was to close that space. And yeah, you can see the TAD down there on the lower so that they don't shift the midline over as they close the space. Here's another proactive case, some pretty ectopic positions of those lower second bicuspids, and in 9 months using 2 manual osteo-perforation applications, they were able to get this result. I remember when I first did Invisalign, we would have to use some sectional mechanics to upright the teeth. That might take 6 months or 8 months, and then we'd be in treatment for another year to year and a half. So a case like this, you know, 5 years ago was a 2-year case. Sometimes even more with the lack of predictability with the attachments that Invisalign was using. So to be able to turn something that would, you know, take 18 months to now 9 months, that's a pretty significant change in the world of orthodontics. In the concept of exposing permanent cuspids on a growing patient, a teenager is actually not a very difficult procedure. But on a non-growing patient, on an adult, it is an extremely difficult procedure. And if you start incorporating perforation into those scenarios, they become dramatically more predictable. So here's braces with perforation. It was for canine extrusion. They didn't use it for anything else. It took 6 months using 2 perforation things, which typically in an adult patient like this might be a year to do something like that. So to cut it down by almost 50% is pretty significant. Here's another sample of 2 palatally impacted cuspids. They were exposed, and buttons placed on there for this procedure. And then perforations were done all around these cuspids. And within 6 months, they're in the right place. And they maybe could use a little bit more facial root torque, but they got into the right place in a very short period of time. Here's another situation, also similar, impacted canines, 6 weeks progress using 1 perforation. So you can see how high that cuspid is, and then after 1 perforation, what ends up happening and how those things come into place real quickly. Pretty significant to go from there to there in just 6 weeks. It kind of blows out most of our normal predictions where we were thinking about just moving teeth like a millimeter a month. That's 6 weeks. That looks like 4 millimeters of movement without any negative sequela. It's definitely significantly different than what we've done in the past. So here's a patient, a class 3 patient. They did braces with perforations, 5 months of progress just using 2 perforations, and you can see a dramatic change in the patient's bite. Of course, they're also using some pretty smart brackets there too. Here's a molar uprighting scenario, which normally we would tell patients would be 6 months to a year, and this was done in 3 months. It wasn't done by me. It was a case that was done out of NYU. The mechanics are good here too. They've got a stabilizing wire plus a spring wire to intrude and measly rotate the lower third molar there. Pretty nice results in 3 months. I mean, that when you look at that pano to get that tooth upright in that period of time and still not lose the vertical position, that's a really nice treatment result. Here, this patient was treated by Dr. Gwynn. 1 month progress. I mean, to intrude gingiva like that, intrude all those teeth to get rid of that gingival display, that's really nice. And you can see she is using some smart mechanics with some TADs and some springs and things like that. But this is 1 month progress using manual osteo-perforation, reduction in vertical maxillary excess, change in patient's gummy smile is almost gone. And you can even see it's actually having an effect on her profile too. So here's another anterior open bite case, considered very difficult to close. With 4 months of using 2 perforations, this case was transferred from Dr. Lala from another orthodontist after 1 year of unsuccessfully trying to close the open bite. A year after the completion of treatment, the bite remains very stable. And that's what I'm finding too, is that even though we might be moving faster, we're not seeing instability in these cases. Here's a scenario with braces where they did some perforations. You can even see the perforations. And this is just 1 month of progress of how quickly those laterals have come down and things have started to level and unraveling of the lower incisors. Here's another proactive case of closing an anterior open bite. And you can see even with that edentulous space, everything closed down nicely. And this was 11 months using 2 perforation applications. This is another proactive case with 1 month using 1 perforation. And you can just see the resolution of the crowding in really short order. Here's another scenario with space closure. Took 6 months only using 1 perforation. Another scenario, a crowded out or ectopic position of a lower incisor. 7 months using two perforations. Closing of a molar space, 4 months, 2 perforations. Here's a little bit more complicated mechanics, but basically 10 weeks with 2 perforations, and you can see that we're doing some pretty cool molar uprighting there in a fairly short period of time. So you can see that molar change there to get ready for some implants there. And then here's another scenario where we were closing up some spaces and correcting a little bit of a deep bite. This was 6 months with using 6 perforations. So this is 1 perforation per month or every 4 weeks to get everything closed up. So that was pretty fast and a little bit different. I think this was before the new modalities were in place. Here's another patient, great closure of an anterior open bite. This is 12 weeks using 2 perforations. Pretty significant change. Here's another anterior open bite, 13 months using 3 perforations. That was with braces. Here the lower left first bicuspid. This is just showing, before treatment, 2 months without any perforations with using braces, and then 2 months after using the perforations. You can see the rotation of the bicuspid happens significantly. So here are some more photos with showing you clinical cases using high-frequency vibration. These are not my cases. I don't have any high-frequency vibration cases to show you tonight. I will in the future, but this is a case by Dr. Dorfman, Dr. Ala Dorfman, and this was 8 weeks, aligner 8. Patient had excellent aligner seating, and so what they're looking at is with better seating of the aligners, they're finding a little bit more predictability in the treatment. So this is another case, initial and 11 weeks. You can see how things are tracking a little bit on the reliable side or very reliable side. And then here's another scenario. This is aligners. This is final photos, 6 months to go from here to here to change that overjet and the resolution of the crowding. Patient had excellent aligner seating. So with better aligner seating, we're able to see more predictability in how things are finishing. And so here's another scenario, 25 total aligners in 5 months using high-frequency vibration. You can see a nice resolution of some of the initial problems. Here's another patient, also, this is by Dr. Brigham, a different doctor in Arizona, 7 months of treatment and 1 week, 24 total aligners, and you can see the resolution of the spacing there on the upper arch before and after, and some of the crowding rotations. And then these are some of my studies, some of my patients that I've treated. This one on the left side was 4 months with just 1 perforation. And then this patient was a reactive case. This photo here, the largest one, was when he originally started, and then a year and a half later, I really was getting no resolution of the spaces, and then after only 1 perforation treatment is when I started to get space closure and things moving along. So I'll kind of show you how this case went about. It started in 2010. Here, this is January 2011, a year later or more, and I still can't seem to get the spaces closed. So we decided to do a perforation. This photo was taken in March of 2014, but the perforation was done in August of 2013. And you can see how there's been a dramatic change in the spaces. And then we continued on with closing spaces, and we were able to get things finished, but it took a little bit longer. If I were to do that case again, I probably would have done a second perforation. After that August 2013, I probably would have done another one in November. But this is how we did it. He only wanted 1, but we were actually able to get it finished. This is also a quite complicated case, bilateral posterior open bite case with missing teeth and a little bit procumbent profile, protrusive, lips are parted. And so with her, you can see her pano, how proclined her anterior teeth are. And in the Sep, we really wanted to make a change in her profile. So here's the pano, and you can see that we're missing a second bi and a first molar there. We're missing a first molar here. And so we decided that we're going to actually take out two bicuspids. So we took out the two bicuspids on top, and then we're going to close all the spaces. And so there's the pano. That's what it looks like as I'm leveling and aligning teeth. And I did one perforation treatment in May of 2013. I did another perforation in July of 2013. So this is sort of the progress photo in April of 2014. And you can see all the big spaces are closed there. And we're still working on our midlines. We're still working on our bite on the right side. There's our progress of May of 2014. There's the pano showing what it looked like after we closed those very large spaces. And you can see her profile change is pretty dramatic, and her bite is getting corrected. And at the end, this is what she looked like. We had to finish her in a class 2 molar relationship, but a class 1 cuspid. Midlines were slightly off, but dramatic change to get all those spaces closed and really change that profile. So there's her initial, 5 of 2010, and here's her final in September 2014. Most of us would say that's a pretty long case, which it is. But the results are pretty significant. There's the cephalometric tracing, so you can see the upper incisors really came back quite a lot. And there's the final pano. No root resorption, no bone loss, no major negative sequela from before and after, with a very difficult treatment plan. To consider that we moved those roots through the bone, maybe 20 millimeters or more. That's a pretty significant change. I don't believe that could happen without using some of the smart mechanics and the perforations that we did. So there's her before and after. Another case, this was actually quite easy when I first looked at her. I said, oh, you just got a couple little spaces, that's going to be no problem. And of course, whenever you do that, you think something is going to be really, really easy, and it doesn't turn out quite that easy. So here, she was post-surgery. She came to me several years after having surgery and braces, and the spaces had come back, and she just really wasn't happy with them. So you can see the surgical plates there. And so I figured those surgical plates are way up there in the maxilla, so they're not going to have any effect on the space closure, and this is just going to be an easy case. So after I get to about June of 2014, I still see a couple spaces just not quite closing the way that I want. I decided to do perforation. That perforation was done in February. And so here's our progress in June, where we're actually starting to see spaces close. And you can see I've got multiple things closing spaces here, springs and power chain. And so we got a lot of stuff working there for us. And so here's the progress, and here's the progress in September. And so all the spaces are now closed with the one perforation. And there's her treatment and results. Another case that was quite complicated, I'm not so sure anybody's seen something quite this complicated, but this is something that I did. This cuspid is actually between the lower right central and lateral. It's referred to as a transposition. Most of the time what we do nowadays is just bring the tooth between the two teeth, because the idea of bringing the tooth down and over into the right place is just considered impossible. Which that leads me to this next case, which is basically a transposition correction, where I'm doing reactive mops, and I'm using passive self-ligation and TAD. So I didn't start out with using mops, but I did introduce them a little bit later, and you can see why. I started this case in January of 2012, and I wasn't really started with mops until the beginning of 2013. So in the Sep, you can actually see the cuspid down here in the transposed position. So there's a pano. Closer look. And so what I did was I told the surgeon to expose the tooth and to tie the wire to the arch wire, the gold chain. And so instead of her tying the gold chain in between the lateral and the first bi, she tied it into the area where it's most probably going to go. It's going to go between the central, and so the central and the lateral there. And so that's what the surgeon left for me, which actually created a little bit of some attachment loss later on. And so nowadays, whenever I do these things, I usually work with a periodontist to get that exposure. Because some of what I did was subgingival, it's a little bit hard to show you extraoral photos and really describe what happened here. And so what I did was I used two TADs, two temporary anchorage devices with a spring. And so what I'm doing is this is the spring the TAD that's holding the spring, and this TAD is just basically holding the spring down so that I can create as much of a horizontal force vector as possible. And so this is what I started doing. I started pulling the cuspid over into the cuspid place. I'm doing this all subgingival. And of course, everyone said, oh, you're going to kill that root of the lateral, and you're going to create more of a problem. And I said, okay, well, let me see how much more of a problem I'm going to create. Personally, I don't like lower lateral incisors to be functioning on upper cuspids. And so I thought the idea of creating an improved functional relationship by bringing the cuspid into the right place would be the right thing to do for her since she's so young. So I continued to keep dragging this tooth over. I ended up taking out one of the TADs. And then by the time the crown of the tooth was in the right place, now I was running, well, how am I going to get that root over? And so this is when I start to introduce Propel. So I introduced Propel, or perforation, in October of 2013. You can see the tooth is now exposed, but the crown of the tooth is going in this direction, and the root of the tooth is, towards the midline. The other teeth in the arch, are both top and bottom, are doing fine, so I'm not doing any perforations around there. I'm really just doing it around that cuspid. So we did one perforation then. We did some progress photos to kind of show you what's happening as I'm trying to pull that tooth into place and bring that root around. In the meanwhile, I end up kind of changing the arch shape a little bit. I was using a TAD also to help me with uprighting the tooth and trying to apply the force in the center of rotation. And you can see I'm using force application from both the facial and the lingual here to try to pull that tooth into the ridge. We're even using some elastics from the upper arch to help extrude the lower arch so it can come back into occlusion. Because as we were pulling that cuspid out, the other teeth around it started to intrude a little bit. So there's another progress Propel, and there's another, and you can see we did get a little of some attachment loss, but we were able to successfully get the cuspid into place from a transposed position. That's pretty significant. And there's the pano. We do have a crown-root ratio of 1:1. Not as favorable as I'd like, but definitely not the kind of damage that I was expecting to have happen there by doing this type of treatment. And the patient was super happy, and so was I. Here's another patient, reactive MOPS with incognito. So we started with a lot of crowding. Incognito is a very challenging appliance, lingual braces to resolve that crowding. So this is a progress photo of 6/2013. So this is already a couple years into it, and you can see there's some big spaces still left. So I decided I'm going to start doing some MOPS. So we did some MOPS in June and then some in September, and there I go. Then the space starts to close, and we started really progressing a little bit faster with that. And then we kind of slowed down a little bit on the class 2 correction, and we got done in November of 2014 with a really great result without flattening the profile and extracting teeth and resolving both upper and lower with incognito braces and some reactive MOPS. Another patient, this was a proactive, so we did this at the beginning. And so she started out, initially we estimated 24 to 30 months of treatment. She's got a bilateral posterior crossbite, an anterior open bite. She's got crowding on upper and lower arches, long lower face height, and incompetent lips. And basically we treated her with MOPS and incognito on the upper arch and clear braces on the lower arch. And we closed the skeletal anterior open bite in 17 months with 3 MOP treatments and no surgery. Her lips are still a little bit incompetent, but I think the overall result is great. I tried to convince her to go do some cosmetic dentistry to change the look of those front teeth, and as of yet I still haven't gotten the pictures from that change. But pretty significant skeletal change, and here's a post-retention image of her about a year and 1 month after we finished treatment. And you can see she still never did the veneers there. Additional proactive cases. Here was another one where we estimated 12 to 18 months with treatment, and with 9 months of treatment and 2 perforations, we were able to complete her deep bite and crowding. Here's another patient, very deep bite. This is a proactive MOP, so we started right from the beginning. I told her right from the beginning, deep bites are very difficult to correct with Invisalign, and she said, okay, no problem. And so there's showing you with the actual MOPs. You can see the perforations, and that's when we did the first one in September of 2015. And then she sends me this picture, and I'm like, what? She's like, I've got an allergic reaction to the MOPs. And I started freaking out. Oh my God, I see this picture, and my team starts telling me, oh my God, you got to call the patient back. She's freaking out. Look at what happened to her lips. And So I call her back, and I'm like, oh, what's going on, what's going on? I was like, that must be fake, and she starts laughing and laughing. She's like, oh, doctor, don't worry, those are just wax lips. And I was like, there is just no way that she got an allergic reaction like that. But she sent me the picture, and my whole team started laughing, and it became kind of a funny joke in the office. But those are actually just wax lips. And for maybe like 30 seconds or something, I thought that it could have been real, but I knew that it wasn't. So here's mop number 2 to continue to correct her deep bite and resolution of crowding. We did that in January of this year. This is our progress photo in April. So some really nice resolution of the deep bite and crowding and rotations, and really a great finish there. And I'll have the final photos in there for you, the next presentation. So marketing accelerated orthodontics to help grow your practice. Let's talk a little bit about how we're going to apply some of these things. So when will my treatment be completed, I think, is the #1 question that we get asked all the time in relationship to orthodontic care. How will my patients pay for treatment when I finish early? I think that that's something that needs to be addressed in your practice management concepts prior to introducing this procedure. And so depending on whether you're doing it proactively or reactively, you can make that decision if you choose to charge them. Do you want to charge them an upgraded fee for finishing early? I personally think it does warrant that fee, especially if you're doing it in a proactive way. What if I finish before they complete their payments? That becomes a little bit tricky, depending on how you set up your contract or how your collection department is set up. That either will work or not. Some people are okay with extending payments past the treatment time. Some people are really adamant about collecting all of the fees prior to finish. Is this going to take more doctor time? I think it will take more doctor time for the procedures, like osteo-perforation, vibration. There is no doctor chair time, and the overall doctor chair time will be dramatically reduced by finishing the case early. Now, I put some contract language in there. If you do finish early and you have this in there, it says if the active phase of treatment is completed before the agreed estimated time, the full fee is due and payable at that time. So that I have in my contract, and we make it clear to them that that's our policy. We do offer to change or update the payment plan at any time, and so there are some patients that don't believe that they will get acceleration, and so we don't shorten their treatment time, do some acceleration. And as we get closer, 4, 5, or 6 months to the end of treatment is when we start to readjust their contract so that they're not going to have a huge balance when they get to the end. And we do always have the patient sign an informed consent that lets them know what it is that we're doing and why we're doing it, so that they're informed and we're covered. One of the things that we find by finishing treatment early is that we are actually able to create more capacity in the office. And so either you're going to have to start more people to fill in that gap, or you're just going to have to take more time off of work, but you're going to be just as equally as productive. So I apologize in advance if you start incorporating this into your procedures, but you will like it. I tell you from my own experience. Your capacity will grow using MOPS if you schedule and collect properly. If you don't plan on the scheduling, changing the overall intervals to shorter time frames, then the treatment time will probably still end up the same. And if you don't collect properly, then sometimes you might find yourself behind the 8 ball. So I definitely recommend that you have that already set up when you're going to implement accelerated treatments. You will have shorter intervals for braces, and you will have longer intervals for aligners. So we will tend to see the patient's overall less number of visits because we can go a lot faster and we can dispense more aligners at each appointment. Advantages to finishing treatment early. I mean, this list, or what I'm talking about, aren't really all the advantages. All the advantages I think you guys already know. We're going to see reduced negative sequela. We're going to not see decalcification, root resorption, all of these things that have been associated with orthodontic treatment over the years, and it allows the patients to show off their great result in a much shorter period of time. So will this set me apart from other doctors? I believe it will. I think there's a window of a few years here. I think that everyone's going to get on board. It will attract new patients looking for faster treatment. It will set you apart. If Invisalign differentiated you, or maybe now doing sleep dentistry, or doing, maybe it was cosmetic dentistry, maybe 15 years ago. If something differentiates you, that's what's going to set you apart in your area. So if you can offer something that other people are not, that's kind of cool. Reduce overall treatment time by 40 to 50%. Increase confidence using Invisalign allows for 7-day intervals, and I even showed you scenarios of 5 days or even 3 days. This is typically how I'm going to charge. I'm going to charge $250 per treatment, either pro or reactive. Like I said, in some situations where it's reactive, I might even just do it for free. If I charge for the whole treatment, I might charge $800 to $1,200. I've heard people charging $300 to $800 if they're going to only be doing 2 treatments. Patients usually will need 2 treatments since the cellular response lasts up to 12 to 16 weeks, and the tips are valued anywhere between $115 to $150 a piece. The dock locator is something that you get put into once you start purchasing devices and things from Propel. There are some keywords that you can add to your SEO if you want to start driving more traffic into your office in regards to faster treatment. And there's some various different brochures and marketing pieces that you can incorporate either into your office or for mailer, direct mailer pieces or things like that. There's some letters that you can send out to doctors in your area or to existing patients or general practitioners. You can encourage parents or siblings. You can promote specials in your office to offer $250 off, which would basically mean 1 free Propel treatment, and then they could pay for the second one or the third one if the third one's needed. There's different little posters and brochures and things like that that you can put into your reception area to show before and after pictures so that patients can trigger the conversation to ask you about this new modality that they could potentially use for themselves. We have display brochures, that talk about our services and talk about Propel and show before and after cases. And we have some brochures that tie in general health to orthodontic, treatment and improvement of overall dental health. And then there are the brochures that are created by Propel that specifically show the reduction in treatment time with using the perforation devices. And then on our website, we have a page that's dedicated for perforation. And so these are a couple other samples of other people's home pages that have developed that same presence or written blogs on the topic. And so that concludes my presentation for this evening. I hope that everybody got something out of it. Using manual osteo-perforations and vibration to grow your practice is really what we're looking at. And I hope that I've gleaned some insight into that area. I do have a little bit of time for some question and answer, so there is a question feature there. If you do type in some questions, I'm more than happy to read the question and then answer them at this point in time. So if anybody wants to have any questions answered, you can. Or if you want to directly email me, there's my email address, and I'll be more than happy to respond via email as well. So thank you for your time. Thank you for your participation. And I hope that the information that I was able to share with you would help to further successfully treat your patients in a shorter period of time, more reliable and a little bit more predictable. Osseous modulation is definitely the wave of the future in orthodontics, and I was honored to be able to give this talk. So if there's any questions, go ahead and start typing them in. I'm more than happy to answer them. I'll read back the questions so that everybody can understand what's being asked. This was asked by a doctor, it looks like. It says, is the effect of Propel the same as extracting a tooth? If so, why would you do both? Well, I think that the effect of Propel is to create inflammation in a localized area. And for example, if I'm extracting a third molar, that effect of the extraction or creating the inflammation is not going to have an effect on my anterior teeth. If I'm extracting a bicuspid, for example, the effect of that inflammation is not necessarily going to have a major effect on the movement of the anterior teeth. It probably would have an effect on maybe like the cuspid and the second bicuspid, but probably not so much on the molars. And so by creating inflammation in the areas where you want the teeth to respond, it's a little bit different than doing extractions. But just so you know, it does work under the same phenomena, the RAP phenomena, the regional accelerated phenomena, that if you create inflammation or high amounts of trauma to the area, you're going to get an effect. And so yes, whenever we do have extractions, we typically do find in those areas that the teeth are going to move a little bit faster. I mean, the bone is also more dense, right? We're not moving teeth into an area where there's a thick bone created there. Whereas in some of these cases, we were showing you where there's loss of teeth, and there's a new ridge that's formed, and we're actually closing molars into an area where there haven't been teeth for a long period of time, which I think is much, much different than trying to close or move a tooth into an area where an extraction space has occurred. So on that same concept, a new accelerated treatment is called surgery first, where we're actually doing orthodontic surgery prior to actually putting the braces on, and then treating the patient, every week or 2 weeks to finish the treatment in less than 6 months by doing the surgery first. And that's that same concept: create as much inflammation as possible so the body can respond quickly. So if so, why would I do both? I don't think that Propel takes the place of extracting teeth, and I don't think that extracting teeth takes the place of Propel. So extracting teeth usually is done because we've got too much teeth and we don't have enough room inside the mouth, or we're trying to change the presence, or kind of like in that one case where we showed the teeth were really procumbent, we're trying to retract the teeth, so then we start taking out teeth for things like that. But typically the effect of an extraction might only last maybe 3 months or 4 months at the most, and then that's it. Then you're not going to get any more wrap phenomena in anywhere. So with Propel, you can localize it to the areas that you want. Typically, we're seeing a lot of problems with like lateral incisors on the upper arch not getting resolved with Invisalign, and that phenomena is gone now with the use of perforation. So next question, do you find that you need to pull elastics during retention phase, or is that accelerated as well? I find that in the retention phase, I'm typically not going to be using any elastics because I'm considered done. So in my retention phase, I typically am not going to be continuing with active treatment type mechanics. If someone didn't resolve their AP correction to begin with, then possibly they might continue with some type of elastics in the retention phase. That's not a normal scenario for me, but I have had a couple patients or two beg and plead that they can continue wearing rubber bands with their retainers long term because they just were really not good during the treatment. So I have done things like that, but that's not common. Do you find they need to pull elastics during retention phase, or is that accelerated as well? I don't think that retention is accelerated. I think that retention is something that's forever and is something that we have to maintain long term. And so I think that the retainers have to be worn for the rest of their life if we want the teeth to stay in the position that we put them in after we're done. And so whether the patient was accelerated to get to the final result or not, I think that retention concept is going to be the same. But fortunately enough, we are finding that with accelerated cases, we're not having to be overly concerned about retention. In other words, removing the teeth too fast and things aren't stable and they start falling apart, too quickly. So someone said thanks to my question answered. So thanks, Michael. highspeedbraces.org. Yeah, so if there's any other questions, please feel free to let me know. Ask away, and I'll be more than happy to answer. But overall, it's always a pleasure, to speak to a group of people that are interested in wanting to advance their techniques. I don't think that anything that we do today is going to stay the same in the next 5 to 10 years. And so as long as we're always keeping up with the most current advances, then we'll be able to offer the best and highest quality treatments to our patients. So thank you guys again for your time and desire to learn. And please reach out via email or look for my article in Orthodontic Practice. It gives you a big, even more broad overview of what I talked about today. And if there's any way that I can help you, just let me know. And thank you very much for your time. And if there's no other questions, which I don't see any other questions being propagated, I'll give some people a couple more minutes if they have any other questions. Sometimes the questions are as interesting as the lecture. No more questions. Well, good night, everybody. Thank you for your time again. And there's my information if you need to reach out to me. And I appreciate your listening. Good night.